start talking about common investigations in gastroenterology. So this is a kind of a general topic. It is a general topic. The idea is, if you could do this in gastroenterology, in cardiology, in nephrology, in pulmonary, then it makes it easier for you to choose between different investigations. Learning clinical skills is something very important as a clinician. So these clinical skills includes listening to the patient, sitting with the patient, gaining confidence. Patient gains confidence in trust you in your decision, trust you in there's a kind of ثقة بالإنجليزي شباب. Trust between you and the patient, and then you listen to the story, to the history, and then from that you examine. Examination is also important. You may reach an idea about what is going on, and then you may want to confirm that by some investigations, so you can take an informed decision to make a plan of management. Being successful in reaching a management includes all of this. حتى في الأشياء الشرعية يقولون الحكم على الشيء فرع عن تصوره. Making a decision is from getting a good insight about the problem. So, what are the common signs and symptoms of gastroenterology? Any volunteer? Sorry? Abdominal pain, yes. Nausea, vomiting. I would make the abdominal pain more located. So, who said abdominal pain? Yes. So, let's say we divide it into epigastric, periumbilical, left lower quadrant, right upper quadrant. In each of these we might think different. So what else? Nausea, vomiting. Yeah. Jaundice. Yeah. Burning sensation. Where? Epigastric burning sensation. So it might be difficult to differentiate between epigastric pain and the epigastric burning sensation, and maybe the burning sensation that goes to the chest, which is the heartburn. Epigastrium and to the chest also, retrosternal. What else? So let's see. Dysphagia is, what does it mean? Difficulty in swallowing. What is the difference between dysphagia and odynophagia? Painful swallowing is odynophagia. Globus sensation, what is this? Globus. What is global? Food stuck in your throat. Okay. Something similar. What is globe? A globe in Latin.
Distinction.
No, in Latin. I'm talking about languages now. In Latin, globe is a ball, a sphere. So, globus sensation, a feeling of a ball sitting in the throat. So, believe me that some doctors will say that there is a dysphagia, which is difficulty in swallowing, while the patient explains just globus. Patient will say in Arabic, I have غصة. I have choking like feeling. This is the translation in English. بالعربي يقولون غصة كثير من المرة تشوفون. If you ask them, do you have any problem getting the food down? They will tell you no. Food and fluid is getting down easily. I have no issue swallowing. So what do you mean by غصة? What do you mean by choking? Choking feeling, choking like feeling. They'll tell you that, oh, there's something sitting here. So this is a globus sensation, it's not dysphagia. And many reports I receive mentioning dysphagia, I ask the patient, it is different, it's globus. Because this carries, if there is dysphagia, then you have to do endoscopy, rule out anatomical narrowing, benign or malignant. You may consider doing manometry, but if it is globus, you think about other causes such as ENT causes, such as chronic sinusitis, chronic pharyngitis. You think about gastroesophageal reflux disease causing laryngopharyngeal reflux, and these kind of things. Halitosis is bad breath, mouth ulcers, which comes with many diseases such as connective tissue diseases or GI diseases, heartburn, what you mentioned, heartburn is the burning sensation retrosternally. Chest pain is a pain in the chest, epigastric pain, nausea, vomiting, regurgitation, and differentiate between regurgitation, please, and vomiting. Regurgitation is unintentional stomach contents getting back to the throat, while vomiting is a contraction of the stomach causing a forceful projection of the stomach material. Weight loss, jaundice, fever with abdominal pain, hematemesis, coffee ground vomiting, diarrhea, hematochezia, melena, abdominal swelling, tremors. Tremors comes with what? Flagging tremors. Yeah. Which called hepatic encephalopathy. Yeah. So establish indication and diagnosis of H. pylori. Let's move to some of these investigations. Because if I have epigastric, now if I have upper GI symptoms, it is not in the slides, but let me explain it. I have someone with upper GI symptoms. So upper GI symptoms, I'm trying to see this pain. Is it epigastric pain more or heartburn more? I'm thinking about gastroesophageal reflux disease, or I'm thinking about causes of epigastric pain. What are the causes of chronic epigastric pain? Try to help me to think. Okay, gastroesophageal reflux disease, yes, could give you epigastric pain, but typically it should give you with it heartburn and regurgitation. Peptic ulcer disease, thank you. Or gastritis. So peptic ulcer disease in stomach or duodenum, or just inflammation of the stomach, which is gastritis. So what else? So the cause of the gastritis or the ulcer could be H. pylori. Yes, okay, what else? So one entity, let's talk about peptic ulcer disease, gastritis, induced by H. pylori or just without H. pylori. Second thing is acute pancreatitis. Acute pancreatitis, believe me or not, it will give you the same location of pain like the peptic ulcer disease, epigastrium. Epigastrium. If you divide your stomach, the abdomen into 9 areas, the epigastrium is the one in the middle and top. So acute pancreatitis, it may go and radiates to the back. So what else? Symptomatic gallstones will give you epigastric pain if the gallbladder is not inflamed. So these are the 3 things. So if I have epigastric pain, mainly, I may, before doing endoscopy, I first need to check if there is any alarm features. Alarm features is something that indicates doing further workup, which is if there is vomiting, if there is vomiting of blood, if there is difficulty in swallowing. I'm thinking about either peptic ulcer, either lesions, tumors in the esophagus, tumors in the stomach, if there is weight loss, if there is family history of gastrointestinal malignancy. So if there are alarm features, I should do further investigations. But if I have someone with epigastric pain, which is a very common cause of visiting doctors, I can do the strategy of check and treat. Check H. pylori, if positive, treat H. pylori. Helicobacter pylori. Helicobacter pylori, as you know, is a bacteria that causes gastritis. It is a bacteria that lives in the stomach and causes peptic ulcer disease. So you take a good history, you ask about the pain. Pain is epigastrium. You can do 2 things. Without referring the patient, without doing endoscopy, you can do ultrasound abdomen, looking into the gallbladder, being sure that there are no gallstones. Okay? Number 1, واضحة? Number 2 is I can do check and treat for H. pylori, for Helicobacter pylori. Okay? So if there are alarm features, or if the patient is older, 55 years old or more, you do and do endoscopy to look into the stomach and esophagus. So what is the established indication diagnosing and treatment of H. pylori? One is active peptic ulcer disease. Two, confirmed history of peptic ulcer disease. Three is mild lymphoma. And after resection of gastric cancer, these are the three things is you have to check for H. pylori and treat it. How can I check H. pylori? So anyone with a gastric pain, you may check H. pylori. If it is positive, you may treat it. H. pylori is very common. But how can I check for H. pylori? What do you think?
Breath test.
Breath test, one. Right. You can read it. What do you think? Sorry? Biopsy from a endoscopy biopsy. For what? You do the endoscopy sentence for what? Two things. Either you have a quick test, you take the sample in the endoscopy room and you put it in a quick test tube called a rapid urease test. The color is yellow, it will turn to red if it is positive. Okay? So this is one way. You put it in a material that changes the pH, and if it is positive, it will turn the color to red. Very easy test, quick. It takes 10 minutes. You may wait for 1 hour for optimal result, or you may keep it for 24 hours. But very quick test, easy, and you can apply it with endoscopy. The other thing, you take the histopathology and send it for checking H. pylori is you can do breath test, you can do blood test, serology. But blood test is like the COVID test. It will continue to be positive even if there is no active infection. So think with me, if you are allocating resources for these tests, if you are planning H. pylori testing and the Ministry of Health asks you to do family medicine in primary healthcare clinics, what is the best test to implement? They want to choose two tests, for example. Breath test and stool test is good also, yes. What else? What about serology? Serology, we are getting blood for CBC, electrolytes. Why not do H. pylori at the same time? So first, we don't check somebody who is asymptomatic. Till this day, we don't check. Okay, if somebody has a gastric pain, we don't check. But we don't announce, for example, and sit like doing whatever. We can check other, screening tests. But for H. pylori, we check only if there are symptoms. If there is a gastric pain, we think, is it more of colicky pain that happens after eating? Is it a biliary colic? Then we think more of doing ultrasound to rule out gallbladder stones. Okay? If it is just a gastric pain, we may check for H. pylori, and if there are no alarm symptoms, and if it is positive, we treat. Serology, the problem with serology, what do you think? In a community with high prevalence of H. pylori, serology is not very useful because you will get it positive in most people and then it might not be useful. But in some countries, for example, maybe Scandinavian countries, when the H. pylori prevalence is low, you may do serology, and if it is positive, you treat. Serology is useful in a low prevalence community, number one. Number two, if somebody if someone gets proton pump inhibitor, such as omeprazole, the H. pylori test usually will be false negative. I mean, the breath test and the stool test will be false negative. Why is that? H. pylori tends to not appear in the test, even the biopsy might be false negative. You know the principle of false negative?
Yeah.
Anybody needs more explanation of what is false negative, false positive?
So what do we do in this case?
So what we do is we stop the medication for 1 week, for 2 weeks, and then we do the test.
What about the people who cannot stop the omeprazole?
This is a question we don't know. I don't know the answer, but probably if there is someone with a very strong indication to do, for example, life-threatening GI bleeding in the hospital. If you have GI bleeding the blood tends to shed away the bacteria from the surface of the stomach, and then the test, even the biopsy, might be false negative. But this is a strong indication that might lead to peptic ulcer, which may affect the patient's life. So in this case, you have two options. If there is life-threatening GI bleeding, either you treat empiric, you just give antibiotic, regardless of any testing, this is one, or you do serology. If serology positive, you treat. If serology negative, you don't need to treat. So this is the application of serology. So serology is one test. Second test is urea blood test and stool antigen. They are more or less similar. They can test for active infection, and in negative, if someone gets treated, it will disappear. So this is urea blood test and stool antigen, and even the urease test by endoscopy, even the histopathology. So these four tests indicates an active infection if they are positive. So breath sample for urea blood test, blood sample for serology, stool sample for stool antigen, and endoscopy tissue sample. All of them are checking for active infection except serology. It requires scope. Scope is something that you will need to think when you want to do it, because it takes resources. It has a cost. So the endoscopy is needed in the last one. Post-treatment monitoring, all of them are useful except the serology. So if you treat and then you want to check eradication, you do serology is not very useful because it will remain positive. Remember it as the serology for COVID in the blood. It will remain positive even if you have recovered from the infection.
Is H. pylori infectious?
Yes, it is infectious. It may move by maybe, but it is very common, very prevalent, and a lot of people has H. pylori. Maybe between 30% to 50% of people carries H. pylori. In the past, we were thinking about treating it or not treating it, and the thought was, do you know who discovered H. pylori? Or who described the H. pylori is known for a long time, but they thought it was a flora, a normal flora of
There was a doctor who
Ingested it.
Yes,
ingested
yes.
it himself, right?
Thank you, yes. I need the story. What is the
To
story?
prove that it causes
Okay.
ulcers.
And what is the story of this doctor? Very inspiring story. If you want a TED Talk story, you can, TED Talks? Yeah, you can use this as a TED Talk story. This doctor was in a small university in Australia, and he describes H. pylori as the cause of peptic ulcer disease, one of the main causes. As we know, two main causes of peptic ulcer disease are, one, H. pylori, two, use of non-steroidal anti-inflammatory drugs, NSAID. So these are two main causes of having peptic ulcer disease. So they thought that H. pylori was part of the normal flora until this doctor, his name is Dr. what?
Barry Marshall.
Thank you, Marshall. Yeah. So you Google it?
Yes.
Yes, okay, thank you. So Marshall, and what did Marshall? So Marshall said, this is the cause of infection. If you read the old books, they will tell you stress, spicy food, and
Medication.
we know that a very severe stress, such as being in ICU, might cause peptic ulcer disease, but regular psychological stress will not cause, spicy food will not cause peptic ulcer disease. So he described that H. pylori is the pathogen. It is pathogenic. It's not something normal flora. He put the proposal, he wrote a paper, they didn't believe him, so he ingested the H. pylori. He put it in a bacteria dish and he swallowed it. And he had endoscopy before and endoscopy after, showing normal stomach, inflamed stomach with gastritis, with severe gastritis. He got antibiotics and he proved that it got eradicated. Again, they didn't believe him. They published the paper in a very small journal. Nobody knows the journal. He sent it to important journals in US and UK, but they did not accept his paper. And now, what happened 10 years after this discovery? What do you know? Do you know what happened to him?
The Nobel Prize.
أيوة.
He got
شكرا.
the Nobel Prize.
Yeah, he got Nobel Prize 10 or 15 years after that. And you know how strong are the articles, the medical publications? Yeah, with citation. So if you have an article, how many people refer to your article? How many people cite your article? And this will get, the article means that this is an important article that changes the science and and maybe changes the medical practice, and the journal will be also a good journal. So this article was one of the most cited articles in history. For example, I should put this article here when I put this lecture, if I'm talking about H. pylori, but this is a general lecture. So one of the most cited articles in medicine. So moving to gastroscopy is looking into the stomach by camera, useful to look and diagnose and treat. You may diagnose reflux esophagitis when looking into the lower esophagus. You may, okay, this is endoscopy, you can see peptic ulcer, you can treat peptic ulcer. So it is one of the GI modalities in investigations. One modality is called, so we talked about H. pylori modalities of diagnosis. We talked about endoscopy. We're talking about now manometry. Manometry is looking into, I'm biased by the way, this is not a common thing to be done in GI, but because I do manometry, I put it here in the third one. It is not something that is used commonly. It tells you how strong and normal is the peristalsis of the esophagus. It is esophageal. There are other manometries, anorectal manometry. There is gastroduodenal manometry, colon manometry, sphincter of Oddi manometry. But the most used one is the esophageal manometry. The main indication is of doing the test is dysphagia. So dysphagia. The other indications could include refractory gastroesophageal reflux disease. Also, you may do it in chest pain, because this is a normal swallow. I can explain this normal swallow, the one on the top right. How this happens: when you swallow, you open your upper esophageal sphincter, the food goes down. So because of the esophagus is peristaltically moving, pushing the food down, and there is a relaxation of lower esophageal sphincter. So blue is low pressure and red is high pressure. So when this is the upper esophageal sphincter up here, when someone wants to swallow, he relaxes the upper esophageal sphincter, pushes the food at the bolus down, and then there is a peristalsis in the esophagus and relaxation of lower esophageal sphincter. This is the lower esophageal sphincter. Okay, so this is, believe me, is a normal swallow. We agree?
Yes.
But what do you think about this one? If this is normal,
Extra.
this patient has chest pain. This is hypercontractile, what's called jackhammer esophagus, very strong contraction. We look into also the lower esophageal sphincter, and in this patient down here, you can see the lower esophageal sphincter without a swallow. This one, both of them are without a swallow. You can see another line down. There you have two lines, is that right? The lower line is the diaphragm, and the upper line is the lower esophageal sphincter. This patient has a hernia, and part of the stomach is above the diaphragm. So you are seeing two lines. This is one way of diagnosing hiatus hernia. So manometry could tells you if the contraction is weak or strong, if there is hiatus hernia or no hiatus hernia, if the lower esophageal sphincter is relaxing or not relaxing. I will look into this in more details in the part 2 of the lecture. So pH monitoring, it looks into the pH in the lower esophagus if someone has gastroesophageal reflux disease, because not all reflux will cause erosive esophagitis. Some reflux will cause reflux without ulcer in the esophagus. Okay, called what? What is the disease? It's called gastroesophageal reflux disease, huh? Okay, so it is called non-erosive reflux disease. So GERD and NERD. Wireless capsule monitoring, you attach a capsule in the lower esophagus. This is one way also of monitoring reflux. Impedance study, okay, this is a little bit advanced. You hear about pH study and impedance study. Impedance is a catheter that has electricity sensing. The change in electricity in kilo ohms might happen up or down in the esophagus. Upper, you have 6 probes. Each one is sensing how much conductivity is there. If there is change in the conductivity of electricity, you see these changes. So look into the left side to A, and could you see the change happens first up or first down? Up before down. Okay, what about B?
Down.
Down before up. So in A, the person drinks something that lowers the conductivity, becomes easier. So there is a swallow. In B, it is a regurgitation. And in this way, we could measure how much regurgitation is there, either acidic or non-acidic material. So these are the things. ينتظروني افضل موظفيك ايوه ممتاز ضروري نتكلم الموضوع بالتفصيل بس شفتك في حالة شيء بس ضروري خلينا نتكلم الموضوع So I'm very sorry. Like, this is called the impedance study. So it is advanced, but you know, if you don't learn something advanced, you will not progress. Know it, familiarize yourself with it. For example, you see advanced echo. You are not required to know it now, but at least when you understand the principles, then you can build on this and understand. What is this impedance? Impedance study is a study that tells you that there is change in electricity by kilo ohm. بالعربي معاوقة كهربائية. By electrical terms, change in kilo ohms by the impedance. So it measures how much regurgitation happens, acidic or non-acidic material. Okay, you can utilize also imaging such as X-rays, and you can do barium swallow. A contrast patient can swallow. In this case, patient is swallowing something, and the esophagus is getting dilated, and there is a narrow lower esophageal sphincter. What is the disease? Chalazion. And a normal, there is a barium meal. Look into the stomach, an old study. We don't use it as much now, but if, for example, someone has a stomach surgery, you want to understand the shape of the stomach, you may utilize this test. We have CT scans are more useful nowadays.
Doctor, is the barium swallow where they make them drink a lot of water?
Um,
Is that like equivalent or something?
Drink a lot of water. No, the CT scan usually they ask you to drink a lot of water. The CT scan, computed tomography. Normal barium meal, small bowel follow through. They drink a lot of water in small bowel follow through. Most of the imaging in the GI imaging, they require you. You can ask your radiology rotation, but require you to drink a lot of material, water and contrast. It might have IV contrast and oral contrast. So this test is not used as much now because we have a better test called CT enterography. Barium enema, useful in looking into conditions in children called Hirschsprung's disease. Hirschsprung disease is a failure of relaxation at the rectum. Gastric emptying test, this is in nuclear medicine. Test tells you how much material continues in the stomach after 4 hours. And if more than 10% of material is not cleared from the stomach by 4 hours, this is a delay in gastric emptying, indicating a possible gastroparesis. Remember, you need to rule out gastric obstruction first by endoscopy, and then if the stomach pylorus opening is patent and there is no obstruction, it is all functional, then delay in gastric emptying indicates gastroparesis.
Gastroparesis is obstruction?
No, obstruction is mechanical obstruction. Is, for example, a tumor at the duodenum or pylorus. This is not a gastroparesis.
Then what's gastroparesis?
Gastroparesis is a delay in gastric emptying due to slowness of the stomach. The stomach is not moving. So a transient study called Sitz marker study is also a test that helps you in diagnosis of constipation. If you ask the patient to swallow a pill that has markers, some rings. If they distribute equally in the colon, this is a slow transient constipation. This is after a few days. You take several X-rays. So the person will swallow the pill. You take an X-ray after a day and 3 days and 5 days. If all the material accumulates down in the rectum, this is what we call outlet problem. So this is a slow transient, and this is a defecation outlet problem. Functional outlet obstruction. So also a useful test. And so in this test, what do you think? This is slow transient is B. Functional outlet obstruction is C. So what do you think in this patient? Is it slow transient? So this is slow transient. You know, in C, something called dysynergic defecation. Patient will not push enough and can improve with something called physical therapy exercises. Anorectal malmotility is another test that also looks into main indication is fecal incontinence and chronic constipation. It looks into the strength of the anal sphincter and push in the rectum. And then it can rule out Hirschsprung disease. Just for example, you push a balloon. There's a balloon in the rectum, and then they inflate the balloon. If there is failed relaxation, this indicates a possible Hirschsprung disease. If it is very short, it will not appear in the barium minimum. A balloon expulsion test asks the patient to push a balloon, also for functional outlet problems. If echography, you may have something called rectocele, either difficography or MR difficography. Rectocele is outpouching here from the rectum, as you can see. Moving to other modalities that combine endoscopy and imaging. If you have an ultrasound, you can have also an endoscopic ultrasound. So as you know, air is the enemy of ultrasound. So if you do a transabdominal ultrasound from outside, the gases in the bowel will obstruct the view. What if I want to look into the head of the pancreas or the body of the pancreas? I have, so one of the ways is endoscopic ultrasound. What if I have a lesion in the stomach wall or the esophageal wall and I want to look into it closer? I can use endoscopic ultrasound. So I can take also FNA biopsies, and you see the needle here? The needle is exactly from this lesion, the rounded lesion here. And there is a test called ERCP. If there are piles stored in the bile duct, the ERCP is an endoscopy. The camera, usually by scope, is at the top of the scope. And by ERCP, the camera is a side view camera. So the camera is on the side of the tube, and it allows you to see the sphincter of Oddi easier, and then you can pass some catheters and bring the stone out. And this is an ERCP. ERCP also combines imaging with endoscopy, because you have a fluoroscopy machine and you have the endoscopy. You take a fluoroscopy picture and endoscopy, similar to what is happening in cath. In cath lab, they use the imaging and they put the catheter. But in cath lab, they move the catheter by their hand from the, for endoscopy, we have an additional thing. We have a camera also that we can see. So we have the camera, the tube inside, and then we pass the catheter. And you can see here the arrow is pointing to what? Okay, there is dilatation in the common bile duct, and what else? So the common bile duct, by the way, is 4 millimeters. How can I know this is dilated? So I'll give you some practical thing. See the scope? This ERCP scope is a big scope, maybe around 10 millimeters. So, and this is almost the same caliber as the scope. So this is about 10 millimeters dilated common bile duct. But what is this? The pointer is pointing toward stone. So what is it? Radio opaque or radiolucent? Radiolucent, yeah. So a stone that is here. So this is an ERCP. You can diagnose and you can do diagnostic and therapeutic. And there is also something diagnostic only without, because going here is risky, has some side effects of manipulating the area might induce acute pancreatitis or bleeding or perforation. So you can do first MRCP, magnetic resonance cholangiopancreatography, and if you see stones or you see lesions that you want to treat, you can do ERCP as a second step.
Okay, I have this question. And the one before this, is it ERCP? Yeah. So the ERCP, how do you make sure, because the camera is on the side, right? How do you make sure that it does not twist while you're getting it inside? Like, and then it gets.
You know Dr. Fahd Sahibani?
Yes.
Yes. He's the. You can ask him this question because I don't do ERCP. Usually it is the twill twist. It will loop, and there are some techniques to overcome this. But this is very technical and advanced. So colonoscopy is also a test that you can do. Look into colon, look into ulceration, diagnose inflammatory bowel disease, Crohn's disease, take biopsies, see polyps, remove polyps. Capsule endoscopy, you can utilize it for areas that you don't, not easily reachable by endoscopies. You swallow a wireless capsule with a camera, and it gives you a diagnosis. For example, one of the main indications is, what do you think, capsule endoscopy? First, what organ? Second, what is the indication? Colon, yes, colon camera, yes, but it is a double camera. This is a camera from one side. The colon camera has two sides. Colon camera, easily you can do the colonoscopy. Easier, you can remove the polyp, take a biopsy, you can move. So there is a colon camera, but this is a small bowel. Okay, the organ is small bowel. And the use is diagnosis of celiac disease, okay, what else? IBD, what else? What else? You know, first, small bowel, I can diagnose small bowel by imaging, such as CT scan, it's called CT enterography, or MRI enterography. Okay, I can reach it by a scope. What is the name of the scope that can reach the small bowel? Google small bowel endoscopy. How can we do it? Called enteroscopy or double balloon endoscopy. Double balloon endoscopy, a scope that has two balloons. Two balloons, and then you inflate a proximal balloon, distal balloon first, and then you pull the bowel and accumulate the bowel, and then inflate a proximal balloon, and then push a scope like a telescope, like several scopes inside each other. And there are two balloons, one proximal, one distal. You keep accumulating bowels and then pushing a telescope, like a telescope inside. A lengthy procedure, take hours, and you can reach the small bowel. If you diagnose something by imaging or by capsule you want to reach, you can do the enteroscopy or double balloon endoscopy. But also intraoperative, you can do intraoperative endoscopy. You can open the segment and the scope can go through. But anyhow, main reason of doing capsule is not celiac, not inflammatory bowel disease. Main reason is bleeding. Yeah. What kind of bleeding?
Ulcer?
Didn't bleeding courage. What is it called? Radic options. MCQ. Hello? Bleeding. Is it occult GI bleeding? Like hidden GI bleeding, obscure GI bleeding, overt GI bleeding. One. What is occult GI bleeding first? بريم جواب واحد يرفع يده جواب okay أنت answered for that. Occult is clinical silent. What does that mean? That you don't see blood. So you take a sample of stool and then you test it, it is positive. This is occult blood. The useful of occult blood testing is for what? Screening for colon cancer. This is the main indication. Okay? So occult blood. What is overt blood? Overt? Who is good in English? Huh? Who is good in English?
Clear.
Huh? Overt is clear. You see blood. Okay? And what is obscure? Obscure GI bleeding is you see blood, you don't know from where is the blood. Obscure definition. You know fever of unknown origin?
Yes.
Called bleeding of unknown origin. Bleeding of unknown GI origin. If you have a drop in hemoglobin, it's a different story. Like somebody with sudden anemia, Differential might include GI bleeding, might include bleeding in other sites such as the abdomen, intra-abdominal bleeding, or the thigh, or might some hematological causes. But let's say you are seeing blood, you see blood coming out. If you do upper endoscopy, lower endoscopy, esophagogastroscopy, and colonoscopy, and you don't see the reason, then it is obscure GI bleeding. You may do capsule endoscopy.
What was the fourth one? You mentioned fourth.
تأليف الفرط hidden. It's not a terminology used usually. So from this, maybe bleeding is the main cause. Okay, and you can do something called RBC scan by nuclear medicine. It indicates bleeding, or it can tell you if there's bleeding of 0.1 ml per minute. More faster bleeding, you can do it by angiography. The angiography utilization is also, you can embolize the artery that is feeding this bleeding. And CT angiography, selective arterial angiography for patients showed following finding in the distal ileum. Liver biopsy also, if you have a liver that is that you want to know, there's hepatitis, you want to know the cause, you then do liver biopsy and you look into it under the microscope. Fibroscan is non-invasive. You can test with it how much fat is in the liver and how much fibrosis is there in the liver. And thank you very much. End of part 1. Take a 10 minutes break. Meet again at 2 p.m. What do you think?
Thank you.
Thank you very much.